Okay, I have 3 p.m. and I'm going to ask Dr. Kwan to confirm the screen looks good, sound looks good.
The sound is good, but the screen, we're seeing the presenter mode.
Okay, oh, well, that's no good. They're going to see all the answers.
I know, that's not going to be fun.
Un momento. How's that?
That is perfect.
Yes, thank you very much, Anne. Isn't it wonderful that I'm such an expert at WebEx? That is satire, for those who don't know me. I want to welcome everyone to the MD Anderson Cancer Center Integrative Diagnostic Medicine Case Conference. We stress diagnostic imaging as much as we do diagnostic surgical pathology in this conference. It's really one field. May 8, 2020. This is, again, a special edition. It will be lunch and learn if you're in California, West Coast. It's happy hour if you're here in Houston or on the East Coast. And this is going to be bedtime stories for those of you who are in Europe. Okay, we always start with a warm-up. So let's do that. And let's start with imaging. I'm going to call this Neuroimaging Challenge 101. It's a 101 because that's freshman level, elementary. And let's start with 2 central nervous system coin lesions. I'm sure everyone in the audience is familiar with a coin lesion, and it usually occurs in this context, an unexpected pulmonary coin lesion. So usually we're talking about coin lesions. It's going to be lung, it's going to be CT, etc. And here's just one example, and you can see I've circled in yellow the coin lesion. This turned out to be dirofilaria. Okay. Here are 2 patients, patient A, patient B. Use the chat function, enter your diagnoses. So you actually get 2 shots at this, A and B. What's the diagnosis for A? What's the diagnosis for B? And what I'm really asking for is, when I say diagnosis, number 1 on your differential diagnosis list. There's always a differential diagnosis, right? So A is what? B is what? Any ideas? Any takers? Oh, I'm sorry. The answers are popping up. Yeah, here we go. All right. Sorry. I was looking at the wrong screen. Okay, good. All right, let's move on. Pyogenic abscess is on A. It's a T1. It's an axial T1 contrast on the left, and on the right is the DWI. All right, it's actually a T2 trace right here. We'll highlight that. That's classic pyogenic abscess, and then on the right, isn't that a beautiful coin lesion? I mean, that truly is a coin lesion, and it's a meningioma. Okay, do you like that as a meningioma? Or do you not like it? Did you expect me to give you these 2 sequences, the coronal and the sagittal? Well, if I had shown you those instead of the axial at the plane where I showed it to you, we would call that kindergarten level, and I didn't want to back all the way down to kindergarten, right? So I bumped it on up to freshman level. Okay, there will be better challenges coming, so just hold on. Let's do a gross anatomy challenge. Wade into pathology. Again, gross anatomy 101. These are all MD Anderson cases. We don't need to borrow other images from papers, other institutions, etc., because we have enough here. There it is. Diagnosis. What is your diagnosis for this lesion? Anybody identify? Yes. Darshan Trivedi says lipoma, but I'm not. So that's 50. That's a 50% of 50. That's an F. Okay, you got lipoma, good. A lipoma, it has another designation. What's the complete designation? You have to give the anatomic location. So if I were to tell you, oh, we have a patient who has a lipoma intracranial, well, lipoma where? Specifically, this one has a specific name. It's a lipoma of the, or a what lipoma? Any guesses on that? And this is a purely incidental finding. Okay, anyone? Okay, no, all right, here we go. How about higher power? You need to see the anatomy, right? I agree. All right, this is the highest power I have. All right, okay, here we go. Now, the quick question is, here's the point. Lipomas tend to be midline, most commonly, all right? Darshan says mammary bodies. That's close, but it's actually anterior to the mammillary bodies, all right? Posterior to the optic chiasm. This is called the tuber cinerarium, yes. So diagnosis, lipoma of the tuber cinerarium. Here's Archives Pathology Lab Medicine 205, and you can see the beautiful example here in the panel on the left of their example. Fat on the right is the histology. This is a great paper, 2019, Incidental Intracranial Lipomas, 163 patients. And the authors make the argument in their abstract and introduction that this is the largest series of incidental lipomas in the literature, so it should be published. And I agree, that's cool. So let's look at the tables. Here's table 2, anatomic distribution of these incidental intracranial lipomas. And here is a patient similar to ours, hypothalamic, chiasmatic, cistern, suprasellar, or what we would say as neuropathologists, we would say tuber cinerarium lipoma. And you can see, it was 3% in this particular series. And that's a nice table you can study. The widest diameter, look at the size range. By far, almost 75% were less than a centimeter, all right, up here at top, all right, 75%. And the largest they had, oh my goodness, between 4 and 5 centimeters, basically we'll call it 2%. Now remember, these are incidental because they are probably developmental. We're not exerting mass effect, did not grow. That's why they were incidental even at that size. Congenital anomalies, which accompany the lesions, just other incidental findings, if you will. Cavum septum pellucidum, cavum septum pellucidum, recepti pellucidae at Bertie that we talked about last week, corpus callosum hypoplasia or agenesis in 3% of their cases, arachnoid cyst, aqueduct stenosis, colpocephalus. And most of these are expected, probably just random association, very small percentages. All right, question. Here's a question. Is there an interesting histologic flavor, if you will, or variant of tuber cinerarium lipoma, specifically of tuber cinerarium lipoma? And that's why I insisted on giving it its name, all right, at the beginning, and simply saying lipoma, that can be identified on CT scan. And if so, what is the name of that flavor? So is there one? Does it exist? No. Just kidding. The answer is yes. I have one job and I messed it up. Yes, absolutely. CT scan. Why CT scan? That's a big hint. What do you think the histology contains that makes CT such a good imaging modality, better than MR, to detect it? Well, it's got to be something other than fat, right? Yes, Darshan Trivedi says calcification. That's close. All right, Alex, calcification, you're close, but you got to take it to the next level. I'll give you a 50, a high F for calcification. It's not calcified lipoma. Take it to the next level. What is the ultimate in calcification? Yes, ossification, right. Thank you, Michael Paolini. Hypothalamic osteolipoma. Now listen, if you've never heard of hypothalamic or tuber cinerarium osteolipoma, now you have. It's a variant. It's very well recognized. Have we seen cases at MD Anderson Cancer Center? Yes, of course we have. we see everything, right? Okay, let's have a look. This is from the paper I just cited, and you can see this beautiful right here in the center. The fat is very easy to see because it's yellow, and if there was imaging had been done on this, it would have been detected ante-mortem. And here is the histologic cross section, and I'm just identifying with the blue arrows. This is bone. So this one almost had a complete or semi-complete rim of bone, all right, on the imaging. Isn't that nice? That's osteolipoma, right? That would be, I actually have a slide a glass slide, H&E, that I use as an unknown, and all you see, I don't give the fellows any information, just look at it, generate a differential diagnosis. And what did they see? They see maybe a little bit of brain tissue, they see fat, and they see bone. And where do you go from that? Usually you'll get things like teratoma, lipoma, lipoma. It's osteolipoma of the tuber cinerarium or hypothalamic osteolipoma. Did you like that one? All right, that's good. So that's just a little entity to remember you may encounter in the future, whether you're a radiologist or a pathologist. Also, can I make a quick comment? Let's go back to this. Let's go back to that the gross just for just a second here. Look at this. This was unfortunately, this patient did have cancer. The patient did not have head CT or MRI prior to passing. And I always check, the EMR to make sure, because that can be so powerful and can help us so much at autopsy conference. However, so can you imagine having a specimen like this and it just falling into your lap? This example, mortui vivos docent. Mortui vivos docent. The dead teach the living. It's a common inscription, or used to be over autopsy suites and the teaching of medical students. All right. The point is, you never know what you're going to find, and it's not just at autopsy, all right? It's also in surgical pathology, all right? You should look closely. In other words, once you've arrived at a diagnosis, you're looking at H&Es, you decide it's a meningioma. That's great. Don't stop looking. Don't go brain dead. Look at all the slides. Look at all the tissues. See how much you can learn. Is that good? Okay. Genomic Alteration Challenge 101. I'm going to call this a 101. Freshman level. Now, again, let's just quickly review the rules of the differential diagnosis. And for any given imaging feature or histologic feature, genomic signature, or any collection of features, there's always a differential. A most likely diagnosis second, or maybe there's two or three that are equally the first, and then second, third, and then the really rare, the zeros, etc. So the rules of differential diagnosis, rule number one is the statistically most likely, meaning most common. Statistically most common diagnosis comes first, followed by the next most likely, statistically, et cetera, with the albino zeros last. And this rule number two is that the differential diagnosis is subject to rearrangement and refinement, that is narrowing with each new piece of information. So we always start, we know about the patients typically. We're going to know age and gender, and then we would learn about the history. What's the background? Why did they present? Why are they here? And then we had imaging studies, then histology, differentiation markers, molecular signature, and those are all of the different spheres of differential diagnoses, which allow us to arrive at a specific diagnosis. So there's always a differential diagnosis. Now, here's the point. Listen, here's the point. When I ask for the purposes of this conference, and this is supposed to be a fun didactic conference where you get to try things, you get to try it yourself. When I say, what's the diagnosis? What I'm really asking for is what's number one on your differential diagnosis. That's what I'm looking for based on data. It's always going to be data-based. Statistically, for the feature or features, collection of features that you see that I give you, what is it most likely to be? All right. So I'm asking for the number one entity on the differential diagnosis based on the available data. All right. Okay. So with that understanding, let's get back to the Genomic Alteration Challenge 101. Okay. Now this is the question. This is the challenge question. Listen closely. I want to know, in just as few words as possible, what is the most characteristic imaging feature of the entity? Now, I'm going to show you a genomic signature, a molecular alteration signature. And from that, you're going to have to figure out what it means. Well, what are the entities? What's the differential diagnosis? And there's always a differential diagnosis for every molecular alteration. And then you're going to have to know what is the most common entity and what is the most characteristic imaging features of that. Now, see, this is a higher level question. I'm not going to show you an H&E of a meningioma with Simoa bodies and say, what's the diagnosis? We're beyond that, right? Yes, we are. All right. In order to answer this question, what is the most common or characteristic imaging feature? You're going to have to recognize a genomic alteration, number one. You're going to have to know which entity is number one on the differential diagnosis for that alteration. Then you're going to have to describe the single most characteristic imaging feature. Okay, everybody understand? You got it? Okay, are you ready? All right, here we go. And I'll be watching for the answers coming through over chat. The circled gene has the alteration. Just for those who are not familiar with this particular visual portrayal of the of molecular alterations. So the gene that's altered is circled. You're going to have to figure out what is the differential diagnosis. Statistically, if you take all the tumors that exhibit a single gene, this is a single gene alteration, and it's this one, what would be the most common entity, specific entity manifesting that, brain tumor manifesting that, and then what is the most distinctive or just simple? Let's see, Dr. Trivedi said peripherally contrast enhancing. Okay, peripherally contrast enhancing is interesting. I think that may be going for glioblastoma. I love that Dr. Trivedi committed. You need to commit. You need to fail publicly, okay? Because that brings in the hippocampus, right? That brings in the emotion, and then you will never forget, all right? That's a good guess, but not quite. Okay, I'm not going to drag this out. Big ponds. The answer is big ponds. That's the most character imaging signature. Now, this is H3F3A mutation, all right? That's diffuse midline glioma, H3K27 and mutant, right? Now, I didn't ask you what the diagnosis was because once you see histone H3, and H3F3A is the most common, Hist1H3B, see just below it, that's going to be much rarer, but that also the histone mutation can give rise to DMGs. You know the diagnosis is diffuse midline glioma H3K27N because what the pattern recognition of this particular next generation sequencing visual display is single gene alteration, and the single gene alteration is H3F3A, that's histone H3, and it's going to be, that's going to be the pontine glioma. All right, and now here is, I really like doing this. These are eight different patients. So I'm not just showing you one patient. You got to take my word for it. And I'm cherry picking. I'm showing you the 4-leaf clover, the most beautiful example, like you see in textbooks. I'm showing you 8 examples of diffuse intrinsic pontine glioma, of which 80% are diffuse midline glioma H3K27M mutant. Or put it another way, of all DIPIGs, DIPGs, 80%, all right, the minimum, are driven by the histone mutation. And there's 20% of other molecular pathways, and these are confirmed. We typically confirm these. Look at the slightly different alterations. Some are asymmetric, most diffusely, but they all more or less diffusely expand the pons, and as they expand, they grow forward or anteriorly or rostrally and surround the basilar artery. That's a very characteristic feature. Look at this one. I'll highlight bottom row, second from the right. See the basilar artery? That one's completely surrounded. Look at the one just to the right of it. All right, that one's almost surrounded. All right, here's another that's completely surrounded. Some of the others, like the one top right, not quite there yet, but bulging on either side of the basilar artery. Highly characteristic feature, okay? Now, I'll tell you, I think the numbers are changing. When I say most common, this is historically, this is the tumor that we have the most experience with, the most research, but you know what? The numbers are changing. So I would actually accept a second answer, and I would accept big thalamus. And the reason is because the thalamus, unilateral thalamic diffuse gliomas in adults, all right, tend to have a very high incidence of H3K27M mutation, right? And there are more adult patients than pediatric patients. Pediatric brain tumors are rare in general, so the numbers probably will change over time to where this may well become the single most common example. Now notice, again, these are 5 different patients, so you're getting a sense of the flavor of diffuse midline glioma, H3K27 mutant in the thalamus. Note that none of these are so-called mirror gliomas. That's where both thalami are affected equally. They definitely can cross the midline when there's a massa intermedia, you know, the gray commissure, so-called. They can do that, but they originate primary in one thalamus. Also, if you will notice in the third from the left, notice that there's also involvement out here of parietal lobe. That also can happen, but because there is predominant or major involvement of the midline, it's likely to be. All 5 of these patients were molecularly tissue confirmed to be H3K27M mutant. All right. Now, the reason why I'm not showing you any examples of the butterfly bilateral is because it is very rare for the true bilaterals, right, when it's equal, not just a little crossing in the massa intermedia, to be H3K27 mutant. It's other drivers when they're ready. We covered that, I think, either last week or the week before that. Okay, let's look at the other, let's look at the other sites of diffuse midline glioma. Here's a nice example of the midbrain tectum, right, axial and sagittal. Cerebellum, absolutely. Another case, a nice example of cerebellum. Again, all of these are molecularly confirmed examples. The pineal gland, yes, is the pineal gland in the midline? Yes. Are there astrocytes in the pineal? Yes, absolutely. Have we known for about 100 years that glioblastomas can arise in the pineal? Yes, we have. Well, it turns out a subset of those are diffuse midline glioma, H3K27M mutant. There have been at least 3 unequivocal definitive examples reported in the literature. There may be more, but I know of 3. All right, and then finally, spinal cord. I think the example that I'm showing you in the top one here, I'll circle it, that's thoracic cord. The one on the right is lumbosacral. And then the bottom right here in the middle, lower, that is a perfect example of a conus medullaris, diffuse midline glioma, H3K27M mutant. Okay, let's look at the pineal just quickly for a second. Extending the neuroanatomic territory of diffuse midline glioma, H3K27M mutant, pineal origin. Now, this is by the paper's by Dr. Andrea Gilbert, assistant professor of pathology, neuropathologist at University of Texas, San Antonio. And you can see a list of famous people, including, I won't put myself in there. I was lucky to be involved, including the late Dr. Leeds, legend in neuroradiology. Now, here, what is the I'll point that out in just a second. All right, here's what the paper said. Diffuse midline glioma, H3K27 mutants, high-grade diffuse glioma, dismal prognosis. It arises in midline structures, predominantly brainstem. That would be pons is the most common, more common than medulla, thalamus, spinal cord. Few examples in cerebellum, third ventricle, hypothalamus. Only one case of reluctant confirmed pineal of pineal region DMG was reported in 2017 when we reported this case, and that was in a 65-year-old man. So the novel insights from our paper, we report the second tissue-confirmed occurrence of pineal DMG, which indicates the pineal is a legitimate site. We report the first occurrence in a child, which extends the lower end of the age range of pineal DMG. So from 12 to 65, that's an N of two cases. Now, see, I think this is an example of a worthy case report, because at the time that we reported this, there was only one other example, and it was part of a really big series. And so it's very important to confirm that it is real. There is a certain incidence, okay? And we always want to be thorough. This is the imaging figure from the study, and you can see that we even include the MR spectroscopy, the lower right panel, all right? And you can see that the elevated choline is very cellular, all right, diminished creatine, and NAA, and there's even here lipid lactate peak. So we're being very thorough. Let me make a quick comment here. You know, back in the day, the late, wonderful Dr. Bernd Scheitauer, whenever someone was describing, or he would describe a, quote, new entity, something that was felt to be unique and deserving of its own category, he always insisted on electron microscopy to look at the ultrastructure. You know, I think, and I totally agree with that. In our era, I think we now must include thorough imaging characterization of any new entity. And that's why we were so thorough in this report, even including the MRS. There's a histology, and I blocked out in red the immunohistochemistry for the mutant protein H3K27M mutant. You can see all the nuclei are lining up. That confirmed it. One additional paper came out a year after the one we published, Journal of Neuro-Oncology, pineal region glioblastomas display features of diffuse midline and non-midline gliomas. So it just depends. So here you can see this is the one example. They had one example of a H3K27 mutant out of, I think it was either 7 or 9 cases of pineal when they went through their files. This is it. And there is the histology. And again, on the far right, on the far right is the H3K27M mutation. So I know that the one report I'm not showing you that came out before ours was, I think it was a series of 47 cases by Tarek Tehan and Ari Perry at UCSF, and one of their cases was a legitimate pineal H3K27 mutant case. All right, so it's real, bottom line. Also, there's one other lesson here. The other lesson here is, you know, I am using a case report that I am an author on, and I just want to emphasize the importance to the trainees of never miss a chance for shameless self-promotion. All right. That's sarcasm. All right, here we go. Patient number 1. Let's start with the cases then. That's enough of warm up. 31-year-old female, chief complaint: my rings don't fit, my shoes don't fit. Here's the pre-op imaging. Give you a second to have a look at it. And I believe, there we go. For those, again, I know that we have to have viewers who are not familiar with reading basic CT, MRI, PET, studies. So I will help you out. This is the area we're looking at. It's the sella. There is a lesion there, okay? Here is the histology. Now I'm going to ask you what the diagnosis is in just a second. I want to show you all this first. Let me show you about, I think I have 6 or 7 or 8 images of the H&E histology. So take a look. This was a resection of the lesion you just saw. This is the whole slide image. Higher power. Oh, hang on just a second. There we go. All right. Higher power. One more. One more. And there's just one after this. There. I want to stop here with this one. All right. I'm willing to entertain diagnoses. I want to give just a minute for those who want to play to submit your, type in your diagnosis. Somatotropic pituitary adenoma. All right, Alex, good job. Crook's cell adenoma, Anquan, I like that. Okay, what else? There's something else here, something big. Sanjay Singh, acromegaly. The patient absolutely was acromegalic. Yes, definitely. What is the tissue diagnosis? So far, several people have a 50 on a scale of I'm sorry, 0 to 100. You have a score of 50. Now, in the traditional school, that was an F. I think in today's schools, you still get a trophy, right? I think that's how it works. But so far, everyone has an F. What are you seeing in this slide? Am I going to need to back this up? Let's see, what is this? You're sure that is a classic pituitary adenoma? All right, Dr. Harb, granular cell tumor. All right, that's good. You would have to say though, remember the patient is absolutely acromegalic, right? And has the pituitary lesions. So you have to do the rings don't fit, shoes don't fit. How would you explain acromegaly if this were a granular cell tumor? Granular cell tumors do not produce growth hormone. How do you explain these cells? All right, and I think this is really the most beautiful. Can everyone see, here's the point. Can everyone see this cell right here in the center? Big guy right here. What are these cells? And then there's some of them that are smaller. All right, what are these cells? And look at this, I like this one in the center because see the Nissl substance? Yes, Anquan, they're ganglion cells. Absolutely, and the little ones down here, the little ones that have big nuclei, maybe a prominent nucleolus, but no Nissl. Dr. Scheitauer called these ganglioid cells, all right? Anquan says gangliocytoma of the pituitary adenoma, and that, bottom line, that is the correct diagnosis. If you've never seen one of these, this is the best way to encounter it. It's in all the textbooks, but it's like a little song, it's like a one sentence, it's an afterthought. So if you've never seen one and struggled with it, you're never gonna remember what you read in a textbook without a case that's challenged you to go along with it. You could memorize the textbook word for word and you will not recognize the entity on images, whether they be radiographic images or histologic images, if you haven't struggled with it. So you know who I want to congratulate in this case? I want to congratulate everyone who played and failed, because you are the winners of this case because you committed, you're never going to forget it, right? Okay, what's the diagnosis? Okay, this is a hint. I was going to give a hint. The hint was immunohistochemistry. This is neuronal nuclear antigen. See how it's lighting up the nuclei and the cytoplasm of the ganglion cells? It says, yes, they really are ganglion cells. They're not atypical astrocytes, something like that. And then here's the growth hormone. And the growth hormone is lighting up the pituitary adenoma, the somatotroph adenoma. All right? And then here, I use this slide. Oops, sorry, going back. Let me just highlight, let me use the cursor here. Can you see the ganglion cell there? It's negative. Here's another nice ganglion cell, negative for growth hormone. The ganglion cells usually do not express growth hormone. They do express many times something else. Does anyone happen to know what the ganglion cells in this context express? We can detect it with an antibody immunohistochemically. Not every laboratory has the antibody, but it's a simple immunotest. All right, calretinin for Anquan, that's a good thought. It's even more specific. Wait, what are we talking about? We're talking about a somatotroph adenoma. The somatotroph adenoma expresses growth hormone. What would be something related to growth hormone that the ganglion cells might express? And you may not know this. All right, TSH, Dr. Trivedi. Okay, it could be a plurihormonal, but that'd be kind of odd. Like, why would the if they're closely related? All right, insulin factor and Anquan, yeah, if they're closely related, why wouldn't they be? They're in the same lineage. I'm just going to jump ahead just a little bit. This is neuronal metaplasia. It's a metaplastic change or neuronal maturation. It's the same line, but probably maybe because of the maturation that they've lost the growth hormone, but they acquired something else. Okay, here, let's move on and all will become clear. Diagnosis. Here's a report from the literature. Pituitary adenoma with neuronal choristoma, a report of 2 rare cases, considered it a collision tumor or 2 different tumors. Intracellular neuronal choristoma associated with growth hormone producing pituitary adenoma containing amyloid. Mixed gangliocytoma pituitary adenoma. This is the term of choice currently. Mixed gangliocytoma pituitary adenoma. These are the other terms that you will see in the literature and in terms of the descriptions. mixed pituitary neuronal choristoma adenoma, mixed pituitary gangliosoma adenoma, pituitary adenoma with neuronal transformation, pituitary adenoma with neuronal metaplasia, pituitary adenoma with neuronal maturation. These are the terms, and they reflect the hypotheses. One hypothesis, initially it was collision tumor, two different tumors. Then I figured, well, that's kind of strange. Maybe they're related. All right, this is a paper that I want to highlight. This is University of Virginia. The pathologist in the room will recognize B. Lopez. And then there's John Jane at the end. Okay, transsphenoidal surgery for mixed pituitary gangliosoma adenoma. This is at one institution, 10 cases. All right, and that's a fantastic series. Scott Vandenberg used to be was at Virginia, had the huge program there. Let's see, okay, the 10 cases. Let's have a look at hormonal secretion and immunohistochemistry. Look at all the growth hormones showing up, and sometimes in conjunction with prolactin, because they're in the same family. They're frequently co-expressed. We don't even call that a mixed or plurihormonal because it's so common. All right. This okay, so that gives you a hint that maybe growth hormone is the most common, right? And in fact, if you look at hang on a second, if you look at this study, I mean it's the same paper. I'm sorry, Dr. Lopez and colleagues put together all of the literature, 73 patients. That is phenomenal. Now let's break it down. Looking at the endocannabinoid hormone production. This is approximate numbers. I did not pull and check every single one of these papers, okay? But if you just go through the table superficially, acromegaly, growth hormone production, 40 cases. Cushing's and ACTH, absolutely it happens, 9 cases. Pure prolactinoma without growth hormone, et cetera, without acromegaly, 7 cases. And clinically silent cases, 11. Definitely the somatotroph adenoma dominates this, over 50% of those which are active. All right, what about, now let's go back to that question. I don't think anyone answered this correctly. The gangliocytoma component typically does not express growth hormone, but it expresses a related molecule, as did our case, which it was tested for it at a referring institution, and that's growth hormone releasing hormone, GHRH. Yes. Doesn't that sort of make sense? Now, which comes first, you know, the chicken or the egg, et cetera? I don't know. That biology just is not known, but it is known. Look at all of the GHRH in this particular study of the tumors, and none of them, 0, produce growth hormone, but they produce GHRH. Do you like that? Okay, now maybe you learned something today, and if you learned something today, if you had never encountered this, then today has been a good day and a fantastic start to your weekend. All right. Again, going back, this was our case. This is the growth hormone immunostain, and the arrows are indicating negative growth hormone expression. Again, at a referring institution, the tissue was tested for GHRH, and the ganglion cells were positive, which fits the pattern that we've just seen. All right. Now, here's the thing. Again, you could read about this in a book, you know, and it notes that, you know, some pituitary adenomas, you know, it undergo neuronal maturation, and you're never going to recognize it when you get the transsphenoidal biopsy, transsphenoidal resection. You're going to be thinking, what in the world's going on? And you're going to be thinking, this is fantastic. I may be the first person to ever observe whatever this is. If you're thinking that, this is a clinical pearl. If you're thinking that, you're probably wrong. Well, a 99.9% chance you're wrong. Now, here's the thing. Just because you haven't seen it doesn't mean that no one else has seen it. All right, that may come as a revelation, but it is a well-known, recognized foible of the young. Of the kids. All right, so now listen, everyone attending, participating in this conference, you can now never say, I've never heard of that. And for the pathologists, pathology residents, you can never say, oh, I've never seen that, because now you have seen it. In fact, you've experienced it up close and personal. And if you had no idea what was going on with this case based on the history and the imaging and the H&E, all right, now you will be prepared to take on that challenge when you do get a case. And if you stay in this business and you're at a hospital where there are neurosurgeons, you will see this case. It may take you 20 years. It will come. All right. Rare but well recognized. All right, let's do. I think I'm in the mood to do to take a break for a second from the intense stuff. Let's do another newer imaging challenge. I'm going to bump this up to a 201. Okay, everybody ready? All right, get ready to chat. Send me some answers. All right, and I'll move on once someone gets the right answer. All right, diagnosis. What's your diagnosis? I'm waiting. Meningioma, Zainab Harb, that's right. Evans, meningioma. Okay, all right, stop. The question is, why did I make this a 201? Why did I make it a 201 and not a 301 or maybe a 401? Because you've already seen the case. All right, it's the same meningioma I showed you, only I didn't show you the T1 without contrast. All right. See, that would have been a little more challenging if I had not already shown you the case, right? But now the point of it, I showed a different case, but similar to this last week, 2 weeks ago, I can't remember, and that was a very difficult challenge. This one's a little bit easier, but you're looking for similar, you're looking for alterations. So kudos to everyone who got this right. All right, but that's it. I just want to show meningiomas frequently are going to be isointense. All right, to gray matter on the sequences. They can be the small examples. They can be almost invisible on the T1, like in this example. So you have to have a keen eye for detail, be thorough, be disciplined. Okay, current knowledge-based currency. All right, and this is actually the last segment of the conference, and I like having this as the last part. I'm going to test how current your knowledge base is. Are you keeping up with the latest advances in imaging, in the genomics of brain tumors, et cetera? Okay, I'm going to draw from the American Journal of Neuroradiology. Okay, yesterday, to be specific, yesterday's issue of the JANR, EPUB before print. All right, let's see if you're keeping up with the literature. Yeah, yesterday, that's right, no mercy. What's your diagnosis? I'm gonna wait. This is an MD Anderson case. It's not from the article. It's from the MD Anderson archives. Sanjay Singh, GAD, GAD, Michael Evans, a gadolinium deposition. Our neuroradiologists are nailing it. All right, gadolinium. Dr. Harb, that was a noble guess. The question is, the first thing you have to ask is, what sequence am I looking at? What's a sequence? And both of these are T1 without contrast. All right, you know it's a T1 because you can see the white matter is hyperintense to the gray matter ribbon. All right, from at least on the panel on the right, they're both the same thing. And what you're seeing is intrinsic hyperintensity of what? Specifically, the dentate nucleus of the cerebellum. That's the panel on the left. All right, we'll highlight these guys, one on each side. All right, is that definitive or what? And the globus pallidus. I said globi pallidi, plural if you will. That's a very unusual combination, right? And it's not part of normal brain. All right, so this is gadolinium deposition. All right, axial T1 without contrast. That was the hint. It is gadolinium deposition. Good. Now listen. The current knowledge base is not that gadolinium is deposited in, when you have over multiple scans, particularly with the linear chelates in the dentate nuclei of the cerebellum and the globus pallidus, and number 3 on the list would be the posterior thalamus / pulvinar. That's not it. That's like 5 years old, and 5 years old is not current knowledge. We're going somewhere with this. All right. Here's your first question. Now here's the current knowledge. Your current knowledge base. I want 2 answers. Number 1. Name 3 body tissues with greater gadolinium deposition in this scenario. And the scenario is multiple MRI studies with gadolinium, particularly if they involve the earlier linear non-ionic chelates, which tend to let go of the gadolinium. Name 3 body tissues that have more gadolinium deposition in that scenario than the dentate or the globus pallidus. And here's the second question. What other intracranial structure has recently been reported to exhibit gadolinium deposition? It's in the paper, right? Do you know it? Now let me say one quick thing before Dr. Singh or one of our super smart neuroradiology fellows responds. My guess is that Dr. Singh has already looked this up on his iPhone. and Michael as well. Okay, and kudos for doing that. I admire it. Okay, but hold off and let others play the game. All right, here's the paper. It's an editorial, gadolinium deposition safety, seeking the patient's perspective. This is a really good review of the current, not just the patient's perspective. It's a good review of the last 5 years of what has been going on with this particular topic. Let's just look at a few of the things. Gadolinium is a rare earth metal lanthanide series represented by symbol GD. It's atomic number 64. At room temperature, it's paramagnetic, meaning it enhances nuclear relaxation rates, making it useful as a contrast agent. In clinical practice, gadolinium ions are administered to patients not in pure form, which is highly toxic, but in chelated form, so that to reduce or eliminate the toxicity as gadolinium-based contrast agents, GBCA. All right, GBCAs were first introduced in the 1980s because the intrinsic toxic gadolinium, they were chelated. And I love this. If you look right here in the middle of the sentence, it says the early studies pointed out that the stability constant was much higher for macrocyclics or crypt chelates. Crypt means hidden, or essentially really entombed, if you will. The crypt chelates are macrocyclic. I'd never encountered that term. I learned something, all right? But the concerns never received much attention because all linear and microcyclic agents appeared to be safe and well tolerated. And moreover, check this out. Check this out for all the attendees that are listening from Europe. Kudos. Macrocyclic chelates were only initially available in Europe. No, we didn't even have them in North America. And so there was little incentive over here on this side of the pond anyway to study them, like no problem. And in fact, we doubled down with the dosage. I mean, if one dose is good, 2 doses must be better. Double dose chelate administration, all right, for angiography studies. All that changed in 2006 when a possible causation with association with nephrogenic systemic sclerosis came out. So in fact, in 2006, the FDA over here in the States restricted the use of gadolinium in patients that had severe kidney disease. That GFR, less than initially, it was 60 mils per min per cubic meter, and then they backed off a little bit and let it go down to 30. All right, due to this, it's really helped, and for a decade, for one blissful decade, we totally forgot about, or essentially forgot about gadolinium and any possibilities, and then, all right, come around about 2015, brain gadolinium deposition. New concerns have been raised in the past 5 years due to mounting evidence. Unexpected CNS accumulation of gadolinium phenomenon is found to be greater in dentate, cerebellum, globus pallidus of patients exposed to several doses of gadolinium chelates with a linear structure. All right, those are the main offenders. Different countries have handled this over the last 5 years differently. The EU actually removed the chelates with a linear structure for generators from the market in 2017 after a thorough 3-year evaluation. They didn't rush into it. In Japan, it was proposed that to only use the linear ligands when you don't have an alternative, et cetera. All right, here's the bottom line. Let's go to the bottom line. What really counts is whether retained gadolinium in the brain and body is harmful. Is it harmful? To date, no proved causation of any permanent severe adverse have been reported in patients with normal kidney function. Now, there is a proposed gadolinium deposition disease, all right, and but maybe in some other settings other than kidney may be, but that is purely a postulate. There is no data to support it. That's really what's important right now to patients, okay? Here we go. There's evidence of gadolinium deposition with even higher concentrations in the brain and bone, skin, liver. So that was the answer to the first question. Did you know that bone, skin, and liver accumulate gadolinium at even a greater concentration than in the brain, the dentate? Okay, what's the answer to the second question? What other intracranial structure may accumulate gadolinium in the scenario? All right, well, there's no direct relationship with causality. Yeah, I wasn't looking at my cheat slide ahead. All right, what's the structure? Anterior pituitary. All right, this was May 7, 2020, AJNR. Increased signal in anterior pituitary, not yet confirmed by tissue analysis by ion probe. I've talked about that before. We'll review it again at some point. Was recently reported in patients who had undergone serial injections of gadodiamide. Gadodiamide is one of the linears that releases gadolinium. Here's the paper. I've given the PMID. That's all you need to write down if you want to find it. You don't have to put the authors, the year, title. You just PMID 314986162. For the residents and fellows, by the way, you will be doing your audience a favor unless you intend to send every one of your audience members, unless you intend to send them a PDF. All right, and for great numbers, that's not really feasible. All you have to put, you'll be doing a favor when you cite, just put it down to PMID, leave it up there long enough to copy it, and that's all you do, because you can do a beautiful PubMed search, Google, any of these, just by PMID. Okay, anyway, here's the paper, and it's not dramatic. This is the only figure in the paper, and you can see what's outlined here in green on the left. That's the anterior pituitary. You can see the posterior pituitary bright spot, which is the neurohypothesis right behind it. You can see maybe just a slight blush, and we're going to compare it, take the ratio of the signal intensity, the intrinsic T1 signal, with that of central pons, and that's a standard comparison. And they use two different methods. One method, the method illustrated on the left, is to take the average signal intensity of the entire adenoid hypothesis. The other were to measure 5 specific loci of interest, okay, or foci of interest. Okay, and here are the results. These are control brains. The green is method 1, looking at the whole gland. Method 2 is the 5. They give essentially similar results. There's certainly no increase over time. This is between first and second injection of the gadolinium sort of thing. And then here, you can see gadolinium exposed of the two methods. There's clearly a statistically significant P less than 0.001 increase. So the authors hypothesized maybe the anterior pituitary is also accumulating gadolinium. Again, there is no evidence that it's harmful, but it's interesting. All right, so this is just something that you should know. All right, here's the bottom line. What really counts is whether retained gadolinium in the brain and body is harmful, and to date, there's no evidence for that. But the editorial does endorse studying it. We definitely need to continue to study the phenomenon, monitor phenomenon, monitor associations with other comorbidities. Maybe there are other diseases in which deposition in the brain, in bone, in skin is important, and so we need to study that. Okay, so that is your, now again, I recommend this. This is like a 2-page editorial, and I did not cover everything in there. It is a beautiful summary of the entire past 5 years, the basics of what we know, what we've learned, etc. In a nutshell, highly recommended. Okay, I think, boy, it's 3:47. We're going to end early. You know, it's Friday. There's nothing wrong with ending early. I have one last slide, and that is follow me on Twitter. The next Neuroimage Challenge is coming up this weekend. For the last 3 weeks or so, I have posted a neuroimaging challenge. I'll do that this weekend. I'll probably issue the answer on Monday. So follow me on Twitter. Thank you for attending. Without you, there's no conference, and I will see you next week, next Friday. Have a great weekend.